jaw opening, jaw closing, jaw deviation type of orofacial lingual dystonias. Meek syndrome, which is a combination of blepharospasm with jaw, pharyngeal and lingual dystonia, and Brugel syndrome when cervical dystonia is along with hemifacial and oromandibular dystonia and blepharo. Blepharospasm, as we all know, that it is an adult onset focal dystonia. There occur involuntary contractions of the orbicularis oculi, which results in forceful eye closure. Orbicularis oculi consist of two parts, which is pars palpebrae and pars orbitalis. Palpebrae, it helps in opening and closing of eyelid with the help of levator, while pars orbitalis is for squeezing of the eye. So toxin is injected in the four sides in the orbicularis oculi, typically in the lateral part as seen in the lower part diagram. And as well as there are certain areas which is shown in red which are to be avoided while injecting Botox. Medial canthus, lower eyelid, upper eyelid, and angle of mouth. So comparing the preseptal and pretarsal injection points, 4 injections, as I told, are usually given in the preseptal area. It can also be injected into the pretarsal. We avoid injections in the medial part, and the side effects, as we all know, are the ptosis, diplopia, dry eyes, epiphora, keratitis, ectropion and entropion. For hemifacial spasm, it is the involuntary, irregular, tonic and clonic movements of the face, which is usually involvement of the 7th cranial nerve, which can present after Bell's palsy, hemifacial spasm, facial synkinetic movements where we inject Botox. Usually the sites are orbicularis oculi, frontalis, corrugator nasalis, zygomaticus, rhizorus, orbicularis oris, and sometimes platysma is also being injected in HFS. Coming to the cervical dystonia, it is a type of, again, a movement disorder. So basically, there can be different presentations of cervical dystonia. It can be only anticollis, only retrocollis, laterocollis, torticollis, or a combination of any of these 4. So for different areas we inject different site. Each patient is different with combination of different movement disorders. So patient should be watched carefully. You can make a video of the patient and you can analyze by fine observing that what all muscles are being involved which is contracting involuntarily and how much dose is to be given at what site. So most common sites where we inject in torticollis is the sternocleidomastoid, splenius capitis, levator scapulae, trapezius, semi-spinalis capitis, and also in some cases platysma. So primarily we, for head turning, primary muscles affected are the ipsilateral splenius capitis and contralateral sternocleidomastoid, and secondary muscles are the trapezius, semi-spinalis. So we have to inject Botox after carefully observing the patient, and doses vary with each patient. There is no fixed criteria of injecting this much dose in cervical dystonia. Normally we see response only after 100 to 200 unit of the Botox is being injected in severe cases. For different group of laterocollis, there are different group of muscles. So it is advised to finely observe the patient for at least 10 minutes, decide whether it is only pure antero, only pure latero or retro, or it is a combination of any of this. Then a chart is being made that which muscles are being planned to inject, and then only we inject muscles. For spasticity of upper limb, lower limb, post-stroke, spastic CP, spinal cord injury, spinal cord tumor operated patients, we have to follow this Ashworth scale for knowing that how much tone is being increased, and after injecting Botox, how much Ashworth score is being reduced. So for every movement, you have to again finely observe the patient for the spasticity, like here. As you can see that clinically it is adducted and internally rotated. So potential muscles involved will be pectoralis, latissimus dorsi and teres major. So starting dose can be as high up to 100 units for larger muscles. For flexed elbow, we see that biceps and brachioradialis are being involved. So starting dose can vary from 25 to 100 depending on the patient's spastic status. For pronated forearm, as you can see that pronator teres is the only muscle which we have to inject. And for spasticity of the wrist and finger muscles, all three cases are different. For flexed wrist, FCR and FCU is the most common site where we inject. And for fist, it is the flexor digitorum superficialis and profundus. So dose varies with each large muscle, and we have to decide as per the clinical condition and the amount of Botox brought by the patient. Botox has also been used for trigeminal neuralgia, although it is off-label, but I would like to share that it has a very good response rate among patients. We have to just ask the patient the trigger sites where he is complaining of neuralgic symptoms. Even in the V1 territory, we have injected botulinum toxin in the subacute trigger zones, and it has wonderful results after that. In detrusor hyperactivity, these are the sites where we have to inject. This is for axillary hyperhidrosis. This is for wrinkles, for cosmetic purposes, and this is for chronic migraine. There are many new methods of injecting Botox in chronic migraine, and new modalities are also available. And like we give injectable therapy, subcute injections of monoclonal antibodies, this therapy is also equivalent in efficacy considering chronic refractory migraine patients. So to conclude that Botox has proven to be effective treatment in many types of dystonia, and considering the potential side effects and benefits of treatment, we have to always think about improving the quality of life of the patient. Thank you.
Thank you, ma'am, for the wonderful session. Maybe for the lack of time, we can have one quick question.
Thanks, ma'am, for the wonderful presentation. I have just one question. What is your experience in head titubation, head tremors in patients with essential tremor, or sometimes isolated head tremors is present in some patients? In those patients, which muscles are to be injected, and what is your experience?
Thank you, sir, for a nice question. Actually, I could not cover up every aspect. It was a vast topic. So this part is very important. I am associated to MGM Medical College, where because of some yojanas, we get Botox at free of cost to the patient. So considering financial issues, we get Botox in good number with good units which we want to inject. So for getting good response in head titubation, at least 200 units are to be injected, and we have to observe that which muscles are overacting in the patient, and then only we can decide. And always when you are injecting for the first time, start with a low dose. You start with 50, and then you can step up in the next session after 3 to 6 months considering the response. Because the risk of dysphagia and respiratory infection is high. And as we said, ki whatever side effects are there, even if patient develop ptosis or drooling, angular oris drooping, it lasts for 5 to 6 months, and its effect is gone after that. So side effects, you can explain to patient that it will be temporary only, it won't be permanent. So we reach up to 200 units. More than that, even for literature, it has said 500 units can be given in head titubation and tremors. But that is far too high. So we should go slow and step up the doses. Thank you.
Madam, you have mentioned that it should be used within 24 hours.
Sir, it is said that
Can be used after 24 hours? Yes. Why it should not be used after 24 hours? Is there any study? Because in one of the conference when I asked, of the record, the
Can be
speaker
kept
told
for
can
a
be
month.
used for 7 days. Even I
Yes,
have
sir.
used for more after 10 days.
Yes, sir.
Just
Even
keeping,
up to
but I have
month,
not seen
if
any
we
rejection.
kept, if we maintain cold storage, cold chain, after reconstitution also, it can be used up till 1 month. But as I said, sir, the potency and immunogenicity decreases as we keep for longer. And we usually try to club 3-4 patients together, so it is not a financial burden for the patient also. Like for hemifacial spasm, we need only 25 to 30 units as an initial dose, but 20 units is lost, it is being wasted. So better club patients and use in the same go, because potency decreases when we keep it for a longer duration. Thank you, sir.
Dr. Monica, one question from my side. That after this, say you inject Botox and you want to keep it as a comment that we can use it up to 1 month. There are studies which saying that after 4 weeks, the efficacy is same. The concern is only of that if you are using a single vial and taking multiple intake, so that can be bacterially infected. That is the issue
Yes.
actually. Thank you.
Ji, sir. Thank you, sir. We used to keep for even a month inside 2 to 4 degrees Celsius deep freezer, so it can be stored at that temperature, sir. Thank you, sir. Yes. Sir, your voice is... Yes, sir.
I used to give the vial for 1 month in the in the freezer.
Yes, sir. Thank you, sir.
Thank you, Dr. Monica, for a very nice presentation. Next, I would like to invite Dr. Nitin Chandak sir for his next presentation.
पासपोर्ट खोलो ना पासपोर्ट
फिर भी नहीं आ रहा ना अब चालू करो निकाल के लगाओ ओके सर एक मिनट सर दूसरा वाला तुम्हारा लैपटॉप ले ले टाइप सी टू कन्वर्टर देखना मेरा टाइप सी कन्वर्टर देना हाँ 2 मिनट एक आके एकदम ब्लिंक होके चला गया है ना इसलिए मैंने उसको बोला था पहले फिर दूसरा लैपटॉप लेके
लैपटॉप है
खुल खुल तो तब तक वो देख रहा था तो इसको लगा खुल 5 साल तो गए ना पहले चालू तो कर चालू तो कर इसको कॉपी कर
Hello. Good morning, everyone. At the outset, I must thank Dr. Sanjay Sharma, Dr. Maderia for inviting me here for the talk. It has been nice to be here. We are in Chitrakoot Hall, and we actually went to Chitrakoot. It's a very, very nice place. I'm not promoting Chhattisgarh tourism. It's really a very nice place. Very beautiful. So, my talk here is on what research work we have done in last 23 years. It all started with Dr. Tauri's thought. He was a very great teacher, a very good clinician par excellence, and whenever we used to attend his rounds, he would generate very simple ideas of research, and we would think how he could come out with these ideas, which we never thought about it. And so he started the lab under the guidance of Dr. Daginawala, who was the director. So our journey began in 1998 with a small space being provided in the hospital basement area, and where first meeting was held. And by 2000, lab was converted into a full research lab with Dr. Daginawala as research head. The primary aim of the lab was to undertake research on infectious diseases and various neurological disorders, and the lab was recognized by Department of Science and Industrial Research. So basically, the lab was started with the aim of having basic research on various disorders, neurological disorders like meningitis, tuberculosis, brain stroke, brain edema, zoonotic infection, and various vector-borne infections. So we started with a very common problem. We all know the diagnosis of tuberculosis is very difficult. Many times it's very challenging, and we have number of tests available with it, but still there are problems where we don't know whether to treat it as tuberculosis or not. So what we did was, we did electrophoresis of the CSF of patients with tubercular meningitis, and this electrophoresis showed a typical 30 kD band in patients of tubercular meningitis. We published this in a paper where we published about 45 cases, and where we found that 30 kD band was positive in around 92% of cases. So we went ahead further. What we did was, we took this 30 kD band, we eluted it, and we did immunoblot analysis and did mass spectrometry. And it showed that there were different proteins in that. There was a host protein IgG kappa, Along with that, we found that there is antigen 85A and antigen 85B. This antigen 85B, A and B are the antigen 85 complex, which are identified in blood, which have been identified in blood previously. And this was basically, these are the microbial products of RV3804C and RV188C. This we wrote in a paper showing that the presence of antigen 85 complex in the CSF. Antigen 85 complex is the early secretory antigen of tuberculosis. Its major part is H37RV mycobacterial strain, and it has been previously demonstrated in sputum and serum. We were the first to demonstrate this in the CSF, and we have patented this. So, taking this 30 kD band as a point, we started further research on this. We looked at, what we did was we produced, we got antigen from Colorado State University for H37RV strain, and we produced antibody against this strain. And then we looked at reactivity of CSF with this antibody, and we found positivity of around 86%. Similarly, since we went ahead with one test, our research scientists went on to look other methods of looking at this tubercular antigen. They looked at with the cell ELISA test, and then we also looked at something went wrong. Close this. Then we thought that if the antigen is present in the CSF, there should be antibodies also present in the CSF. And then we looked at IgG antibodies, and we found positivity of this at around 85% cases. So subsequently, since we had this 30 kD antigen with us, we looked at various other biomarkers in the CSF for tuberculosis. We looked at antigen 85, we looked at for 45 kD, heat shock protein 16, culture filtrate protein 10, ESAT 6, all these are tubercular biomarkers. We did various analysis, ELISA tests to look at this antigen. I'm just giving a brief overview, so I'm moving a bit fast. Then we looked, it was thought that antigen 85 complex could be a bovine antigen, and so we also looked at early secretory antigen target 6, which is seen with Mycobacterium tuberculosis. We found positivity of around 80%. Then we looked at other host biomarkers, looked at HSP heat shock protein. We looked at heat shock protein 25, 60, 90, and it was found that heat shock protein 70 and 90 were correlated or highly sensitive for tubercular meningitis. We also looked at there would be a possibility of latent tuberculosis, so we looked at microbacterial dormancy regulatory protein RV2623, which is seen in latent tuberculosis patients, and we followed up these patients for tubercular meningitis, and few of these patients later on developed tubercular meningitis. So over a period of last around 20 years, we have looked at various biomarkers, antigen, antibody in tubercular meningitis cases, and all this we have been using for the diagnosis of tuberculosis. However, we all know that with tubercular meningitis, the level of Mycobacterium antigen and antibody, they differ during various stages of the disease. It may be because of treatment, because of host response. So we thought that we develop a separate kit which would look at multiple antibacterial antigens together. So we developed a kit, we named it as Multiplex ELISA, and it looked at 6 different antigens of tubercular, 6 different tubercular antigens. We also now have an animal lab facility with us. We have, in collaboration with Nagpur Veterinary College, we opened a lab in 2009, and we have developed a mice model for tubercular meningitis now, so that if needed, we can do a research further on this. In 2012, government relatively banned all the immunological tests because of lot of issues of sensitivity and specificity. So our lab also moved towards molecular approach. We developed a new duplex PCR test, which together it looks at two genes, 16S DNA gene for bacteria and IF6100 gene for Mycobacterium tuberculosis. This was designed in such a way that both the antigen, both the genes could be detected with one single test. And the advantage being that the cost was low, you required very less amount of CSF, and the test could be done rapidly. We presented, we wrote up a paper on this, and it had a good sensitivity and specificity. Almost in proven cases, it reached to around 100%, and in those patients where it was suspected, it went to around 94%. Our lab then later moved on to look at various bacterial meningitis patients, and we developed an in-house technique looking at 16S DNA PCR, and we looked at developed a nested PCR for 8 different common bacteria, and we wrote up this paper, and this is our data in last 8 years. On we analyzed around 1,164 samples of meningitis, and this was the relative. This was the organism what we got. Then we also developed, our lab developed viral encephalitis panel by real-time PCR, and we analyzed 8 different viruses through PCR, and this was our data around, we looked at around 1,000 cases of viral meningitis. 91% of patients did not show any activity, which may suggest that probably we are missing these cases, or probably we were not diagnosing those patients who we diagnosed as viral could be some other form of encephalitis or meningitis. This was the ELISA test which we developed to look for viral encephalitis. This was a paper which we wrote on epidemiology of viral infection in our region with PCR. Then we also developed antipeptide antibody against viral antigen. However, the sensitivity and specificity in this was low, which may suggest that probably viral antigen detection may not be right approach to diagnose viral meningitis. Our lab also developed a novel synthetic peptide assay which looked for viral antigen, and this was now we have been applying this technique regularly. We also looked at viral load and the patient's outcome, and it did suggest that the higher the wire load, the bad the patient's outcome. So these are the number of tests which we have indigenously developed for all the neuro infections, and we have been now regularly doing these tests in our lab. During 2006, there was an epidemic of chikungunya in India, and we analyzed patients of chikungunya and neurological infection. This is probably, we were amongst the first to write up on neurological infections and chikungunya. We were also amongst the first to show that PCR positivity in CSF, in chikungunya patients, which may suggest that there was direct intervention of chikungunya virus in the CSF. We looked at, similar to other viral infections, we also looked at viral antigen, IgG and IgM, and here we found that viral antigen was more sensitive than IgG and IgM. We have made a big leap now, we have moved forward, and now we have a metagenomic next generation sequencing lab available with us. We have now installed this lab in our hospital. We have taken up a project which looks at diagnostic utility of metagenomic next generation sequencing approach to study cases of meningoencephalitis in central India. Our target is to look at around 100 CSF samples. Till now we have collected around 70 samples, 30 has been sent to San Francisco, 30 to MedGenome, and 10 we have started analyzing in our lab now. Apart from neuroinfections, we have also looked at something new. This is a study where we did a genomic surveillance of SARS-CoV-2 in sewage in and around Nagpur area, collected sample from around 120 areas, and this has helped us to know, and probably this would help in future also, to know the real epidemiology of what is going to happen in our society. Like we detected second wave of COVID 15 days earlier when it happened, and this paper we published in the Lancet Regional Health Southeast Asia. We have various future plans. We don't know how much it would succeed. We are going to look at autoimmune disorders. We are going to look at neuroinflammations. We also plan to look at gut-brain axis through metagenomic approach. We have a CSF and fecal bank in our hospital. We have CSF sample, around 5,000 samples of various diseases, and we have around 100 fecal bank, 100 samples in fecal bank. We hope that in future we will look into these samples. We now recently have inaugurated our research lab building, which is a 4-storied state-of-art building, just inaugurated. We have our satellite center at Melghat, which is a tribal area near Amravati district, and we look at, we are trying to see various malnourished patients and various infections which are associated in this area. We have published around 136 papers, and we have 6 patents with us. Every research needs funding. Most of the funding in initial stage was from in-house. It was our hospital which was funding the research lab. Over a period of time, we started getting funds from major government organizations also, and recently we got funding from Bill Gates organization. This is our team. Thank you very much. This is the team which is doing the metagenomics, but frankly speaking, last 20 years, many research workers have worked behind this work. Yes, sir. Very nice work done. Very nice work done.
Thank you, sir, for
Very
the
nice
wonderful
work done.
session.
This is what I'm trying to say.
Thank you, thank you.
Thank you, sir, for the wonderful and enlightening session. Now, next I will call.
Just a minute, Arpit. Nitin, it's fantastic. And Raipur also constitute a part of a central India. So why don't we call for our collaborations? And when these tests are going to be commercially available or clinically available for Chhattisgarh? Nitin.
Sir.
Oh. Hello. Hello, Nitin. Mic there. Am I visible now? So, there are the two questions. The Chhattisgarh also constitutes our old Central India CP at Barar. So why don't you ask us to collaborate in a certain project? And we have got a unique spectrum of disorder. And when the tests are going to be clinically available, like an enhance, because you have got that many patent, that many tests available with you. So
All these tests are now available with our hospital.
So how
even
to-
in Nagpur, most of the centers now send these tests. They send as a viral package, as an infection package, and all these tests are done.
so can we send our samples to?
Yeah, definitely. Yes.
Okay, thank you.
Now, next speaker, I'll call Dr. Jayanti Mani for management of status epilepticus.
Yeah, a very good morning to everyone, and thank you to the organizers for this opportunity to speak in front of all of you. I've been tasked to speak about management of status epilepticus, and so I'll just broadly outline, we will just touch upon a few things. That's the definition and some relevant pathophysiological concepts, a little bit about classification, and mainly about what is the management strategy, largely for convulsive status epilepticus. So very early on, as early as 1970, it was Gasto who defined status epilepticus as enduring epileptic activity for a sufficient length of time that makes it unlikely to stop spontaneously. So this was the conceptual definition given. And the key question is, how long is that sufficient time to make it irreversible, right? So at that time, the definition was put at 30 minutes because seizures that went beyond 30 minutes caused irreversible brain damage in animals. So that's how we came up with this concept, and that was for quite some time. But more recently, over the years, this period has been getting shortened, And it was some pioneering work and then, concepts by Professor Lowenstein that changed the idea that convulsive seizures rarely last beyond 5 minutes, and if they do, the likelihood of them stopping is very low. So we should consider this as practically as status epilepticus, and operationally anything beyond 5 minutes should be considered status. The other definition also includes 2 or more discrete seizures where there is no recovery of consciousness in between. So the important thing is, why has this definition changed, right? Because what has been observed over the last 50 years is that a mean seizure, tonic-clonic seizure, usually lasts about a minute. That's an average duration. And when it is 5 minutes, this is 18 standard deviations from the mean. So that is how much of less probability there is of it being 5 minutes. Secondly, longer the seizure, it's less likely to stop on its own. For example, seizures that went beyond about 30 minutes, only 40% of them stopped spontaneously. And also because when seizures last longer, they become more and more difficult to control. For example, benzodiazepines work as effectively as 86% if the seizure duration is less than 20 minutes. Whereas if it's beyond 30 minutes, the chance of it working is just 15%. So we talk of time is brain in stroke, but I think it's even much more crucial in terms of minutes when it comes to seizures. So survival also is a function of the duration of the seizure, and this has been demonstrated as early as 1992. So where you can see that as the duration increases, the chances of survival become less and less, whether they have split it between more than 1 hour and less than 1 hour in this graph, as you can see. So the next question then is, how long is sufficient? So the ILAE came up with this concept of 2 time points. Time point 1, beyond which seizures are unlikely to stop, and time point 2, beyond which the seizures can have long-term irreversible consequences. And T1 and T2 have been defined a little arbitrarily for each type of seizure. For convulsive seizure, it is 5 and 30 minutes. For partial seizures, it is about 10 and 60 minutes. And for absence status, it is about 10 to 15 minutes, and really the duration that leads to irreversible damage is unknown. So while we have been discussing this, we realized that we can classify seizures, just as we can classify seizures in various ways, we can classify status also in different ways depending on how much part of the brain is involved and which type of seizure there is. I'm not going to get into this. Today we will be largely discussing convulsive status. Also, based on the duration of seizures, we define different stages. Stage 1 is early phase up to 10 minutes. Stage 2 is established status, that is 10 to 30 minutes. And beyond 30 up to 60 minutes is called refractory status. And when it goes on even beyond 24 hours, we call it super refractory status. So some important aspects of the pathophysiology, I know it's a very long, biochemical and electrical issues, but the important thing is that there are dynamic changes that happen in synapses as the seizure progresses, and this is also time bound. The ionic channels, the way they are structured, there is much more GABA in the presynaptic membrane, and the receptors are more GABA, but as time goes on, the GABA receptors get internalized, and there is more and more of NMDA receptors that come onto the surface. And this is important because many of the drugs which are GABA mediated, like phenobarb and also benzodiazepines, work much better in the early stages of status. But once status becomes refractory, we may have to use drugs that work better on the NMDA or the AMPA receptors. So also the other things like the neuromodulator expression, like the P-glycoprotein, that also changes with time and makes drugs less and less effective. So I won't get into the etiology and things right now in the interest of time, but stroke is the most common, then comes CNS infection, then among chronic cases, it's often the missed anti-epileptic drugs that we need to remember. Coming to convulsive treatment, convulsive status epilepticus, I think there are some basic principles we need to remember. One is time is really brain. We need to start treatment early, and there is more and more emphasis nowadays about pre-hospital treatment of status. And we need to escalate treatment very rapidly. And this has to be kept in mind. We realize more and more it's not the choice of the medicine, but how quickly and how much of the medication you use. One should not be skimpy about the doses. It's okay to use higher doses in status. Patient can be a little overdosed because that's how you can, grab the situation and get it under control. You should also remember that it's not only about anticonvulsants. We need to monitor and maintain homeostasis. We need to parallelly be looking at the cause of the status, and also remember that while we use the quickly acting medications, we should keep an eye on maintenance therapy as well. So the highlights in terms of what we have out there in literature is that there is really a lot of challenge when it comes to having any kind of evidence-based care, because the kind of data we have is very poor quality, and also there are very few randomized trials. But again, I re-emphasize the need to hit early and the need to hit hard. If we remember this, I think we do a much better management of status, and we need to have a staged approach. What I mean is we need to start in a low and then keep escalating doses. So as I said, this is again reiterating the same thing about impending status is just 2 seizures and things not coming under control. Within 5 minutes, we need to start thinking about what we do outside the hospital. And for pre-hospital treatment, it was this paper in NEJM that showed that we can even use intravenous benzodiazepine out of hospital. This was again a study done by Lowenstein, and he showed that it can be used quite safely. And this is where the mandatory use of benzodiazepine as the first drug of choice in early seizures was established. Now there are different modalities available, and there are some papers here to show that initially we used to use mainly rectal diazepam, but over the years now we have even buccal midazolam, and it has been shown to act faster. And it is as safe, because there was some worry initially that it would not be safe. Intramuscular midazolam, there was a very well done study called the Rampart study that showed that IM midazolam was as effective as IV lorazepam, and even intranasal midazolam, we have trials to show that it is very safe, as good as intravenous diazepam. So this is the protocols we can use. The most quickly acting, and I've just shown you here that this is the intravenous, it works within 5 minutes. Nasal works pretty quickly. The intramuscular can take much longer, 5 to 45 minutes. Buccal midazolam also can take a little longer, and the rectal one is the one that takes the longest. But whatever is available, one should be able to use, and that's the key message. Diazepam, any of the benzodiazepine that are available, one can use them. Intravenous one is a little wary to use in a small center, but once you have moved the patient to main hospital, again the same thing, midazolam can be used IV, and you can even repeat the dose if the first dose doesn't work. In the meanwhile, you also need to take care of the airway and all the other important things for the safety of the patient. Now, once this has not worked, still the next line continues to be phenytoin or fosphenytoin. Again, to use good doses, at least 20 milligram per kg, and we have to prepare phenytoin only in saline, and this should never be forgotten. And again here, if it doesn't work in the first few minutes, you can repeat another half loading dose. The rate of injection is 50 milligram per minute for phenytoin and 150 milligram per minute for fosphenytoin. So that is the advantage of using fosphenytoin. You can give it much faster. The next step will depend on whether you have facilities for an ICU and a ventilator. If such facilities are not available, we treat it differently. And I just wanted to emphasize here how important it is to give phenytoin by a large bore needle, and should always be made in saline, because otherwise you can cause real damage to the limb. And this is an example of, luckily we don't see much of this today. Now, there are studies which have tried to compare in the past phenytoin and phenobarb, diazepam plus phenytoin versus phenytoin alone. There have been few odd randomized trials, and none of them were able to establish any clinically significant difference between them. But then they have always been wanting in the way they were conducted, the systematic methods, so we never had enough evidence. Newer therapies, again the same issues, not enough numbers yet, and limited databases. This paper, which has recently reviewed all the available treatments, is a good one if anybody wants to look at it. It has systematically looked at trials for about 8 drugs in status epilepticus. But the landmark study was published recently in NEJM 2019, and this was a randomized control trial that looked at 3 different medications. Once benzodiazepine has failed, phenytoin at 20 milligram per kg, valproate at 40 milligram per kg, and levetiracetam at 60 milligram per kg. And the good news is that all of them work in about 50% of the patients, and there is really no difference between the three drugs. So again, in the step 2, if you don't have facilities for ventilation or EEG monitoring, then you can go ahead and give the second line drug, which can be any of these 3. And if then after that, get ready to shift to a higher center. In some places where there is facility for monitoring and an ICU setup, there is an option to look at using anesthetic agents right away. That's right after phenytoin. This is debatable. It depends upon the overall general condition of the patient and also comorbidities and the level of sensorium of the patient. So if we decide to induce coma, the options again available are midazolam, propofol, or thiopentone. There's been again few trials which have tried to compare one versus the other. When we use propofol, one has to remember that you will end up needing to do EEG monitoring. The advantage with thiopentone also you will need to do it. With midazolam you may get away without doing continuous monitoring. You can have repeated EEGs rather than ongoing monitoring. The problem with propofol is that one needs to remember that it is sometimes it's a short acting and you can reverse it quickly. That's the advantage with it, but it can rarely lead to what is called propofol infusion syndrome, and one has to be wary of this happening. There are papers which have looked at small series actually, which have compared midazolam and propofol, and in general it seemed like propofol was riskier in this paper, and also that the effectiveness of propofol versus midazolam was not very different, and hence I think more and more centers we are now veering to using midazolam as the anesthetic agent. So the next question is, when you're using propofol or thiopentone, what is the end point that one is looking at, right? So you could look at getting burst suppression coma, or you could just look at suppressing seizures. So there has been some kind of a debate on what is better to do. Earlier we always believed that burst suppression coma is necessary and we need to maintain it for 48 hours at least. But this paper by Rossetti et al., she found that there is actually a greater risk of hypotension when we attempt to get burst suppression. And it was not really that there was any additional value of using burst suppression versus just suppression of seizures. So it is again, the jury is still out whether you really need to go all the way up to causing burst suppression. So while all this is happening, as I said, we need to make sure that other aspects are being taken care, especially acidosis, lactic acidosis, CPK levels going high, myoglobinuria, and also that leading to secondary renal dysfunction. So one has to remember that. And phenytoin when we use, I would like to again reiterate that normally we say anything about 20 is toxic, but in the setting of status, you're okay with it going even up to 35 mcg per ml. So parallelly, we are going to identify and treat the cause. And while that is happening, you've suppressed the patient with the coma or sedated the patient, then how do we withdraw it? So what we need to do is initiate maintenance therapy in good doses. While the EEG is being used, one can do it either with continuous EEG monitoring. If that is not possible, then at least monitor the EEG once a day. If 48 hours we have not had any seizures, we can try to withdraw the anesthetic agent. One has to do it gradually and not abruptly. And after we have withdrawn, we have to still continue to monitor the patient's level of alertness and the EEG, because you have to be aware of a condition called subtle status, especially when the person is persistently confused or comatose or stuporous. You have to watch for small things like nystagmus, subtle twitching of the lips or the cheek, or any rapid fluctuations in blood pressure or heart rate. This may indicate that this is subtle status. The only way of confirming it is through an EEG. You may see things like focal plaids or electrical seizures. So one has to be sure that one is not dealing with a subtle status before we withdraw the anesthetic agent. If this is happening, it is what we call refractory status epilepticus or super refractory status, because here the seizures are continuing beyond 24 hours despite anesthetic therapy, or when we attempt to withdraw anesthetic therapy, there is recurrence of seizures. This is what we call super refractory status. So these are some situations where one deals with super refractory status, that is NORS, and the other condition is fires. And all of us may have come across an odd patient where there are no rules, there are no trials, nothing available to tell us what to do. And these can be highly fatal if not managed adequately. So, and also lead to a lot of long-term consequences. There has been one paper that tried to look at ketamine for super refractory status, and this is where the concept that once seizures become very refractory, the mechanisms that are operating are not benzodiazepine dependent anymore, and that is where the NMDA mechanisms kick in, and this is where ketamine scores over the other medications in being able to block the NMDA receptors, and that's how they stop seizures and also have some neuroprotective effects. So these are some of the other medications, ketamine and isoflurane doses here, just for completing the list. And there are other therapies, some of them oral, like topiramate and perampanel, that works through the AMPA channels. Magnesium, ketogenic diet, especially in conditions like NORS and fires. Again, there are no trials, and one has to remember that when you use drugs like propofol and use a ketogenic diet, it can lead to severe acidosis, and one has to be extra careful about that. There have been also anecdotal reports where in focal status, people have gone ahead and even performed focal epilepsy surgery. There are new trials on things like neurosteroids, because finally inflammation seems to be the common pathway that sustains seizures. So allopregnanolone has been still in the trial stages. Some people have used this concept of the NMDA receptors being the key players and tried to preempt and use benzodiazepines directly with ketamine. And so these are some trials that are ongoing. So as I said, once all this is happening, we have to keep our eyes open for any complications and keep managing those as well. So the outcome of status really depends on many factors. You can see here 15% of convulsive status is fatal. It is much higher in the elderly. If it's refractory status, it goes up to 33%. And interestingly, non-convulsive status, which I'm not covering here in the interest of time, but depending on the etiology, can be as high as 50%. And those who don't succumb to it have a lot of morbidity, functional status going down, risk of further seizures. After a single seizure, the recurrence of another seizure is just 13%. But if you've had status, the possibility of seizures happening again is as high as 40%. So the factors that really make a difference is the etiology of the status, the age of the patient, the comorbidities that the patient has, duration of the status. Now this is something which is really under our control, that we can act quickly as soon as we identify it. Even the seizure type is important, and the level of consciousness. So there have been attempts to grade status and try to predict early on what is likely to be the outcome. So one of them is this test score, which has used same features, that is the consciousness, the type of seizure, the age, and the previous seizure history, to come up with a scoring system. The maximum score is 6, and anything above 3 is a poor prognosis. So I'll end here with just one line about non-convulsive status. That is people who present just with persistent stupor or confusion, as I said, twitchings of the lips or fingers, or some continuous nystagmus, or some kind of abnormal repetitive behaviors. One has to suspect non-convulsive status. This is a whole topic on its own. What is important is that EEG recordings here, unlike in convulsive, you need it to make the diagnosis and start treatment. There are no really signature patterns to make you diagnose non-convulsive. So here is a situation where you may need continuous and much more frequent EEG recordings. And there are no separate kind of protocols as of now for treating non-convulsive status, but one tries to avoid an escalation to anesthesia as far as possible. But having said that, I've had situations where the non-convulsive status doesn't go on, doesn't stop beyond, having used 2 or 3 drugs, and then you do still have to resort to elective intubation. So I'll end here by saying that you really need to seize the seizures, because time is brain and every minute counts, and honestly you have only 30 minutes in convulsive status because you can lead to permanent damage. So I'll end here, and I hope I've finished in time.
Very nice and elaborated presentation, ma'am. We can take a few questions. Any questions?
No, ma'am, I just wanted to say one thing. That still, I think you will have to launch a very big plan of public education for this. Of course, things improve in our country very gradually. When we started practice, I think in 1 or 2 communities in Indore, it was mandatory that if some acute stroke occurs, they will look for the pigeon blood and alcohol. कबूतर का खून लाके उसकी मालिश करना और अल्कोहल की मालिश करना was the first thing which they will do in the richest people of that community, mostly Sindhi community, I am telling you. But gradually, as you know now, there people have started learning at least this much, that there is an injection which is known to be given as early as possible. So many people's mind have changed and turned. In this particular field also, what you are talking, an intranasal midazolam, I think now many neurologists are insisting that you should keep at home who are chronic epileptics and things of that kind. But still, we get a lot of periphery. All of us get a lot of patient from the periphery. And then the time is money, what you are talking is. That needs to be addressed to in a bigger way in any case.
I agree, sir, because when we go to the rural centers, what we find that people don't even have, they have only phenytoin available and nothing else. They don't stock benzodiazepine. So when we go to our rural camps for the last 1 whole year, we have been trying to explain that they should at least have injectable midazolam available, but it is extremely difficult to make this happen. So I hope with this whole IGAP program and all that is happening, we are able to move the public health system in a better way and see that we can, first things have to be made available, and when the guy goes to the center, he'll get something. So you're absolutely right that we need to work at a public health level, and we've started some initial measures, and hopefully the movement that is coming through WHO will get our public systems also into action.
Intranasal, many people have started keeping. Intranasal midazolam, many people have started keeping at home. But then we have to teach them more about it. Because one particular day the incidence occurs, you may get an answer, कि साहब वो मालूम नहीं कौन सी अलमारी में रख दिया था, हमको मिला नहीं 15 मिनट.
That's why in every visit, I try to emphasize the preventive thing and keep asking them whether they have it. So maybe when the patient comes to our follow-up, whenever they come, I think we also need to keep reinforcing, because that seems to be the only way to get people to remember. So yeah, thank you for that comment. It's really useful.
Ma'am, one question. While managing NORS actually, NORS, how quickly you move to ketamine or say to go for the etiology wise like rituximab? Suppose if antibodies have come negative, young fellow has come to you, and it is NORS and fitting into autoimmune encephalitis type of pattern. So do you wait for the same thing, or
So what
because
happens, I
antibodies
think,
are not there actually?
yeah, so if we,
So how do you proceed for that?
if you suspect autoimmune and you have the facility to do it, we typically send it out in the first 48 to 72 hours. One is sending out these antibodies, and it takes at least 2 weeks for these results to come by. So till such time, one ends up using things like, of course, the seizure medications, but steroids, IVIG, and then by the time you have come to about 2 weeks, I would rather wait for the antibody results to come rather than give the rituximab within the first 2 weeks.
Suppose if antibody is negative,
Yeah.
then how to proceed?
Yeah, so then if there are no indicators, and by that time if the status has not settled, then one would definitely want to use it. So while you're waiting and
Yes,
waiting
that
for
is
the
it.
result,
Yeah.
you've used all the other methods, and then if the steroid helped for that matter, then again there is some indication that there may be a role for rituximab, but there is no kind of a guideline as of now.
No. The question was like, should we wait for sufficient time for phenobarbital or midazolam, or we should go for NMDA, this ketamine first?
Yeah, so that is what I mentioned. There's a trial which is looking at directly after benzodiazepine,
Yes.
after the midazolam is given, directly go to ketamine.
Yes,
So
that
there is
is
a
right.
trial that's looking at that. If you're comfortable using ketamine, while you're using maintenance anticonvulsants, if midazolam didn't work, you could directly go to ketamine, but also keep adding the maintenance drugs.
Yes.
So that
That's
when you use ketamine for 24 hours and take it off, then you're hoping that your maintenance drugs have kicked in. And if it is still not kicked in, we already then are suspecting that there is some immune process. So then you will have to start thinking on working beyond adding the steroid, then what after the steroid. So I generally find that using steroid or an IVIG as the next, and then by the time that is done and you are still not anywhere, then rituximab comes in that sequence. So timelines, more than timelines, it's the sequence in which we use it.
Good afternoon, ma'am. One question.
Yeah.
I just want to know some your ideas about the long-term prognosis in survivors of epileptic status, super refractory status, long-term outcome in the survivors.
Yeah, so again, you know, if you notice that the factors that tend to affect this will really be, age is a major factor, and the etiology of the refractory status. I think these two are and the comorbid conditions. So, you know, we had a young girl who came to us within 48 hours, or actually within 12 hours of her first seizure. And under our observation, we are trying various drugs. She went into super refractory status. She was admitted with us for nearly 2 months, right? But after that, she settled to the point of becoming cognitively intact. In 3 months, she went back to college. She was not, you know, performing like at her original level, but she was independent. The seizures were occasional. Now this, if you translate to another scenario, that it is an elderly gentleman who's had a stroke and who has some, also has diabetes and many other comorbidities, already has some cognitive challenge because of age, and there you have super refractory status, I think there the prognosis is going to be extremely guarded. And in fact, sometimes it's fatal because we keep giving injections after medications, and then the option you only have left is to anesthetize and intubate the patient. So then you are stuck between what to do, because what's likely to be the overall outcome becomes difficult. So these factors is what helps you make a judgment.
Ma'am, do you think that as the neurons burn out in status because of excessive firing, so the prognosis is like a hypoxic brain injury?
No, I wouldn't say that. Hypoxic brain, again, everything is a matter of degree, right? So hypoxic brain injury itself can cause status. So if that is the cause of the status, then it is much worse. Whereas if you have a small dysplasia in the brain and that caused a status, or it was a viral infection that caused the status, and that viral infection settles, then your outcome could be much better.
Etiology is important.
Etiology really matters a lot. Age and etiology matter a lot.
Thank you.
Thank you, ma'am. Next, we would like to invite Dr. Girish Soni, sir, for his next presentation. Yeah.
Good afternoon, everyone. Open हो रहा है? Next slide ये है. Meanwhile, can I comment few things about super refractory status epilepticus and seronegative autoimmune encephalitis? I have 5-6 patients of super refractory autoimmune seronegative epilepsy where rituximab also failed, and in those situations we use tocilizumab, pre-COVID era also, and all of these patients they recover over a period of 3 months to 1 year, cognitive wise also, of course epilepsy wise also. In 2 of our patients at the end of 2 years we stop all the anti-epileptic drugs also. So yeah, so seronegative autoimmune epilepsy, it's very common entity where PET scan will be helpful. Variable uptakes in variable part of the cortex is the clue. Frontal showing hypermetabolism, adjacent to frontal parietal area showing hypometabolism, one basal ganglia showing hypermetabolism, other basal ganglia showing normal metabolism. That is the clue for autoimmune encephalitis, PET scan. Yeah. But with seizure, having increased metabolism and decreased metabolism, definitely it might be a clue.
Yeah, what happens is when they are in super refractory status, to send them for a PET is firstly quite challenging. Secondly, because of the repeated seizures, that itself leads to a lot of metabolic disturbance. So which is the cause and which is the effect? Even in the MRI, it becomes difficult to make a decision, you know? Yeah.
So we are going to discuss some focal and rare variants of CIDP. So we all know what is CIDP. It's a insidious onset, gradually progressive, symmetrical sensory motor neuropathy causing proximal as well as distal weakness with hyporeflexia to areflexia and sensory complaints limited to the distal limbs. Lower limbs, upper limb also affected, nerve conduction typically abnormal, CSF in 50 to 70% cases abnormal. Usually we don't do SSCP and MRI neurography in such cases, and they typically respond to immunomodulators like steroid IVIG, and the prognosis is good. There are many variants of atypical CIDP which can present asymmetrically, which can present with pure sensory symptoms or pure motor symptoms, slowly progressive than typical CIDP over a period of many months to years. Time to diagnosis is also delayed. Here nerve conduction studies can be normal, and in such situation for diagnosis we need SSCP and MRI neurography, and the prognosis is relatively good in such entity if we diagnose these entities in time. So what are these varieties or variants? So CISP, CIMP, they are limited to proximal sensory roots before the sensory ganglion, when we call them as a chronic inflammatory sensory polyradiculopathy. If they are restricted to only motor roots proximally, they are called as CIMP, chronic immune motor polyradiculopathy. If both roots are involved, then it is CISMP. And in such situation, nerve conduction studies of the distal nerve segment will be normal. So CISP was first described in 2004-5 by Sinerich. These patients predominantly present with slowly progressive paresthesias, dysesthesias, followed by prominent sensory ataxia, eventually leading to frequent falls and wheelchair bound status along with clumsiness in both upper limbs, no weakness, and typically deep tendon reflexes will be absent. They progress just like sensory ganglionopathy. In sensory ganglionopathy, the NCS will be definitely abnormal, SNAPs will be absent, while in CISP, SNAPs and CMAPs will be normal. So all routine investigations will be normal in such situation, except in 50 to 70% cases, you will get albuminocytological dissociation along with elevation of CSF immunoglobulin G levels. So nerve conduction studies will be normal, EMG will be normal. Here the SSCP will be absolutely needed for the diagnosis. From lower limb SSCP, the popliteal nerve potential will be normal, which indicates distal nerve segment functioning. The lumbar roots N22 will be absent or grossly prolonged, while cortical responses will be prolonged or absent. When we do SSCP of the upper limbs, all responses can be prolonged: earth point response, cervical cord response, and cortical response. And if you do the MR neurography, particularly stir sequences, that will show a grossly thickening of the root segment along with contrast enhancement of these roots, and typically axial sections, even plane, they show a sago grain appearance of the roots. So MR neurography is the additional good investigation to diagnose such conditions. Usually we don't go for nerve roots biopsy, but if you do the nerve roots biopsy, that will show the thickening of the roots along with segmental demyelination, and in 50 to 60% of cases, onion bulb formation. So it is a treatable entity. We should keep this DD whenever someone presents to us with a sensory ataxia with a normal NCS. Then what is CIMP? It typically presents with slowly progressive weakness in both lower limb of lower motor neuron type along with areflexia without any radicular pain, without any bowel bladder involvement, without any history of back pain. That differentiates it from quadra equina syndrome because of spine diseases like spondylosis or some structural lesions affecting the roots and plexus. Here nerve conduction studies will show maybe CMAP amplitude will be lower down if the disease is moderate to severe. SNAPs will be normal. F wave latency, S reflexes might be abnormal because they indicate roots functioning, and EMG will show chronic partial denervation. Again, MR neurography, if you do, they will definitely show diffuse thickening and contrast enhancement of the nerve roots along with sago grain appearance. CSF may show albuminocytological dissociation, and they are fantastically responsive to steroids, IVIG, and plasma exchange. In such entity, usually the duration of treatment will be around 2 to 5 years. You can give a trial of stopping the steroid or azathioprine mycophenolate at the end of 3 to 5 years. In fact, we stopped the drugs in 2 of our cases which we started 3-4 years back. Much more entity than CISP and CIMP is CISMP, which is a combination of roots affection of sensory as well as motor. Here the NCS will be normal, EMG may shows chronic partial denervation, F wave and H reflexes will be absent, SSCP and MRI of the roots and plexuses will be definitely abnormal. There will be definite thickening of the nerve roots and plexuses in such situation, and they show excellent response to immunomodulators. Now we have almost 8 cases of CISMP with us. So points to remember, CIDP can be focal and very proximal can be affected. Duration of such CIDP variants can be very long over a period of years. Nerve conduction studies will be normal in such situation. Always ask for SSCP and MRI neurography in such situation, and they are fantastically immunoresponsive and drug can be stopped in such situation at the end of 3 to 5 years. Now next focal variant of CIDP is MMN, multifocal motor neuropathy, which is again immune mediated demyelinating pure motor neuropathy. It evolves over a period of years and it affects the selected nerves like median nerve, ulnar nerve, followed by peroneal nerve or tibial nerve, and classically it is associated with the conduction block in the affected nerve at a segmental level at non-compressive sites. So it's a rare entity, typically affects the male between the age of 20 to 40, 50 years, middle-aged male. It has a very slow progression, asymmetrical limb weakness along with atrophy for a duration of more than one month history, no sensory loss, predominant upper limb involvement, or upper limb involvement is first followed by lower limb involvement, along with evidence of lower motor neuron affection like absent reflexes, atrophy, fasciculation rarely, no bulbar affection. Cramps are very common in such patients. And exclusion criteria that differentiate it from ALS or MND is absence of upper motor neuron signs, absence of marked bulbar involvement, absence of sensory impairment that differentiate it from MADSAM variant of CIDP or other variants of CIDP, absence of symmetrical diffuse atrophy that is typical of CIDP, and absence of grossly elevation of CSF proteins. They are typically associated with normal CSF studies or minimal protein elevations in the CSF. Why this entity is important? Typically conduction blocks in the affected nerve, and they doesn't respond to steroids. They classically responds to IVIG. Other practical points are, again, if you do the MRI of the nerve, like MRI median nerve, MRI ulnar nerve, MRI of the radial nerve, these nerves typically shows thickening and increased contrast uptake. So MRI of the plexus or nerves for diagnosis apart from nerve conduction studies, and 50 to 70% of these patients, they can have IgM ganglioside GM1 antibodies positivity in the serum. So this multifocal motor neuropathy has to be differentiated from MND, typical CIDP, and MADSAM, whose presentation is completely different than MMN. So in these conditions, steroids are completely ineffective. In fact, steroid can worsen multifocal motor neuropathy. They are extremely responsive to IVIG, and you can give a booster dose of IVIG every 6 weekly, every 3 monthly, depending on the severity of the disease. So this booster dose is around 400 to 800 milligram per kg in a single day. So typically 25 gram to 40 gram for a single day, every 1.5 to 3 monthly. Now, a newer concept of nodopathy and paranodopathy, which can mimic like a AIDP or CIDP like presentation, which are completely a different spectrum of disease of node involvement or paranodal involvement, which typically characterized by prominent conduction block without much temporal dispersion in initial part of the disease, followed by axonal degeneration in the later part of the disease. So if you do the serial nerve conduction studies, you will get a mild conduction block, then prominent conduction block with a minimal temporal dispersion, then axonal degeneration with absence or reduction in the CMAP amplitude over a period of weeks. So that these are nodopathies or paranodopathies where there are various nodal or paranodal antibodies are involved. A classical example is Aman variant of GBS or Amsan variant of GBS. Even multifocal motor neuropathy is in fact a nodal type of neuropathy. So the CIDP-like presentation of this nodopathy is prominently seen with neurofacin 186, neurofacin 155, contactin antibodies, and Caspar antibodies, which can present like a CIDP, where you will not get a concurrent temporal dispersion for that conduction block. So this spectrum of diseases can present acutely or subacute to chronically with a prominent distal weakness than proximal weakness, with areflexia, with sensory ataxia. They have a characteristic poor responsiveness to IVIG. That's why this entity is important to keep in our mind. They respond to steroid, they respond to plasma exchange, and they respond fantastically to rituximab. Because most of these paranodal and nodal diseases, they are IgG4 mediated. And whenever IgG4 comes in the picture, they respond fantastically to rituximab. So, apart from this neuropathic symptoms, neurofacin 155, they have very prominent tremors and cerebellar ataxia. Contactin or Casper mediated nodopathies, they have prominent neuropathic pain, severe burning pain along with myokemia or fasciculation, and they can have a GBS-like presentation. Pan-neurofacin antibody and neurofacin 186 antibody mediated diseases can have a fulminant course and GBS-like presentation along with prominent diaphragmatic weakness. Contacting associated paranodopathies, they have a typical CISP, CIDP-like presentation along with nephrotic syndrome. So contactin is prominently associated with proteins in the urine along with nephrotic syndrome-like presentation. Thank you.
Thank you, sir. Excellent presentation. Sir, I have one question.
Yeah, ma'am.
The booster dose in multifocal motor neuropathy with conduction block, how is the response and how long to give this booster dose?
Madam, how long? I really don't know. But response is good, ma'am. Okay. And I saw only 3 cases of multifocal motor neuropathy till now in last 12 years. Yes. All are doing good with IVIG booster doses. And one patient is on mycophenolate also. Okay. Because the response was not that great, so we added mycophenolate. Okay. All are doing good. How long? Really don't know, ma'am. Okay. Because experience is not that good, to be very frank. It's a rare disease.
Yes, sir. Okay, sir. Thank you. Any question?
Yes, ma'am.
Anyone asking? Dr. Soni, I congratulate you for a nice presentation. I just want to ask you one question, that how will you, in a different scenario, different clinical situation we are facing along with that NCV, so how will we differentiate between that, say, AIDP variant versus acute on chronic CIDP, say acute presentation of CIDP, other than that, if you are not having a classical history related to that duration of a disease, and patient come with that directly respiratory involvement.
Acute presentation of CIDP.
Yeah, versus AIDP if you are not having a clinical detail.
First attack of acute CIDP